gastroenteritis, most commonly caused by viral followed by enterotoxigenic E. coli. Treatment is rehydration. If there is mild to moderate dehydration, we should give ORS. If there is severe dehydration, we should give IV fluids, and we can give probiotics. If there is a dysentery, we should add metronidazole 400 and diloxanide furoate for amoebic dysentery. For bacterial dysentery, ciprofloxacin 500 BD. So pathogenic infiltration of virus and bacteria will cause noxious stimuli of GI tract, and inflammation will cause stimulation of visceral nerve pains, and it will cause abdominal pain. And increased GI fluid secretion will cause diarrhea, and stimulation of vomiting center due to release of 5-hydroxytryptamine from enterochromaffin cells will cause nausea and vomiting. Management of patients with acute watery diarrhea. If there is no signs of dehydration, 50 ml ORS per kg body weight plus ongoing losses. There is some dehydration, 80 ml ORS per kg body weight over 4 to 6 hours plus ongoing losses. Observe patient for 6 to 12 hours and continue feeding, and including breast milk or young children normal feeding. If there is severe dehydration, start IV fluid immediately, 100 ml per kg IV solution containing sodium, potassium chloride and bicarbonate. Children less than 1 year and malnutrition, 30 ml per kg in first 1 hour and 70 ml per kg in next 5 hours. Adults and children more than 1 year, 30 ml per kg in first half an hour and 70 ml per kg in next 2.5 hours. Initial evaluation by history and physical in case of dysentery suspicious for E. coli 100-157H7 strain. Obtain culture, stool culture, CBC, blood urea, nitrogen, and administer bolus of normal saline 20 ml per kg and admission. On admission, monitor for hypertension, volume overload, and monitor electrolytes, RFT, platelet counts, and discharge when platelet count is stable or increasing in case of dysentery. Follow up after 1 day after the discharge and recheck platelet count to ensure continued stability or improvement. Enteric fever is usually caused by Salmonella typhi, which affects the reticuloendothelial system, and symptoms of enteric fever are fever, nausea, abdominal pain, and diarrhea. Treatment: cephalosporins, oral cefixime 200 mg for 14 days and azithro 500 mg for 7 days BD. Both are BD. And IV treatment includes ceftriaxone 2 gram IV BD. So this is empirical treatment of ceftriaxone. And drug susceptible infection in case of typhoid, ciprofloxacin, amoxicillin. Treatment of multi-drug resistant infection include ceftriaxone, ciprofloxacin, and azithromycin. Treatment of fluoroquinolone resistant infection include ceftriaxone and azithromycin. In case of children, antibiotics, ciprofloxacin oral 500 mg BD or ofloxacin oral 400 mg BD and ceftriaxone IV 2 to 3 mg OD for 7 to 14 days and azithromycin oral 1 gram day 1 and 500 mg OD for 7 to 14 days. In severe typhoid, ciprofloxacin 400 mg BD IV for 10 to 14 days and ceftriaxone IV 2 to 3 grams for 10 to 14 days. Dose for children include ciprofloxacin oral 5 to 10 mg per kg BD, ofloxacin and ceftriaxone IV 25 to 50 mg per kg OD. In severe typhoid dose, ciprofloxacin 5 to 10 mg per kg BD or IV 4 to 7 mg per kg BD. Ceftriaxone IV 25 to 50 mg per kg OD. Intra-abdominal infections include biliary tract infections like cholangitis, cholecystitis, and spontaneous bacterial peritonitis, and secondary peritonitis, and intra-abdominal infections, post-necrotizing pancreatitis, and pancreatic abscess. Community-acquired acute cholecystitis regimen is cefazolin, ceftriaxone, and community-acquired acute cholecystitis of severe physiological disturbance and advanced age and immunocompromised state. Then we should add meropenem and levofloxacin, imipenem, and cefepime and piptas, acute cholangitis for after a biliary enteric anastomosis, again cefepime and meropenem, and healthcare associated biliary infection cefepime, ciprofloxacin plus metronidazole and vancomycin. So anaerobic coverage metronidazole and vancomycin. So intra-abdominal infections commonly caused by gram-negative bacilli. Gram-negative include E. coli, Klebsiella, and antibiotics effective are third-generation cephalosporins, ceftriaxone 2 gram IV OD, and cefoperazone and sulbactam, and fluoroquinolones and ofloxacin, and Shigella and Salmonella and Pseudomonas are other gram-negative infections causing intra-abdominal infections. Empiric antibiotic selection in intra-abdominal infections: ceftriaxone plus metronidazole in case of community acquired intra-abdominal infection with less than MRDO2 risk factors. If hospital acquired, severe community acquired, under 2 plus MDRO risk factors are there, piptas or cefepime 1 to 2 gram IV 8 hourly plus metronidazole IV 8 hourly, and add vancomycin per pharmacy for high risk history of suspicion of MRSA. Severe sepsis or septic shock or respiratory failure, meropenem 500 milligram 1 over 30 minutes and 500 milligram IV 6 hours for extended infusion plus levofloxacin 750 milligram IV 4 times plus vancomycin as per pharmacy. MDRO risk factors include more than 7 days of continuous antibiotic therapy in past multi-drug resistant infections, 90 days, and poor functional status, significant debilitation with incontinence and inability to perform ADLS, and hospitalized for more than 48 hours in past 90 days, and immunocompromised state ANC less than 1000, and congenital immunodeficiencies, acyclinemia and HIV, hematological malignancy, and prednisolone equivalent more than 20 milligram it is going, and burn patients. Serious intra-abdominal infections upgrade to piptas 4.5 gram IV 8 hourly and addition of fluconazole 800 milligram on day 1 and 400 milligram on day 2. And in enterococcus infections, vancomycin or teicoplanin may be contemplated. Gram-negative are more serious. So meropenem 1 gram IV 8 hourly or imipenem with cilastin IV 6 hourly. To cover anaerobic coverage, we need add metronidazole 400 milligram 8 hourly. Surgical evaluation and antimicrobial therapy and intensive care, these three are needed to maintain sepsis management. Anaerobic coverage, preferred antibiotics for suspected anaerobic infections above the diaphragm is clindamycin is preferred. Metronidazole misses actinomycetes and microaerophilic streptococci. Below the diaphragm, metronidazole is preferred. Clindamycin misses some of the Bacteroides fragilis, and everywhere beta-lactams and carbapenems and moxifloxacin. Anaerobic infections include Clostridium tetani, Peptostreptococcus, bacteroides, and metronidazole for vaginal infections, and clindamycin 150 mg for anaerobic bacteria and bite wounds and pelvic inflammatory disease.